Good morning, everyone. Hope you all are doing great. Hope that you all are enjoying your weekend. Firstly, I take this opportunity to welcome all of you and pay my gratitude towards you all because it's Sunday today. Still, you all, amazing doctors and doctors to be, are here to learn. So, first clap for you all and pat yourself for being here. Me, Dr. Sadhna, some of you may know me. I welcome you all on behalf of Sattva Charitable Trust. Sattva Charitable Trust is a non-profit organization formed by Dr. Rakesh Gupta. It is working towards improving health and providing treatment to needy ones at a low cost. Also, emphasizing on educating and creating awareness. It is the first NGO to receive the permission for free distribution of preventive homeopathic medicines against COVID-19. Sattva has been conducting various health camps and also working during COVID era to help and support our fellow mates. Sattva is on the way to create a platform, a learning platform, and for the same, it is conducting various health webinars for educating and adding to the knowledge of students as well as doctors. In today's time, homeopathy is blooming. Many of us have successful results while treating chronic cases or diseases which are slow progressing. But what happens when it comes to acute? When it comes to acute, any acute disease or diseases which are fast progressing, many of us homeopaths have a shaking confidence. Let me ask you all, how many of you are confident enough to treat any acute disease? Those who are confident can write in chat box A for acute that you all are confident for treating acute diseases. When patient is in hospital, it is a situation of crisis. It is a situation where you need to take immediate action, where your mind has to be open and alert so that if needed, you can take any action immediately. It is important that we understand what's the presentation, what can be the prognosis and complication, as well as how to manage such cases. We have to be vigilant enough. Also, along with all these things, we need lot of patience and skills of handling patient's relative. For all these things, today we have with us an amazing teacher, dynamic person, one for whom patient comes first. He's a proud homeopath. He's always ready to expand his boundary of learning and applying homeopathy. Today he is there to share his experience with us about acute disease and its management, especially in hospital or hospitalized patient. I would love to say that I recall my experience with him. He's a doctor who is always on his toes for his patient. Let it be 2 a.m. in night, but he does receive phone calls. Also, not only he answers, but he asks us to update about patient every 10 to 15 minutes, even at night, not caring that if he gets enough sleep or not. So he's none other than our own Dr. Rakesh Gupta, HOD of FMT department, CMP and HMC. So guys, are you all excited to learn? Are you all ready to learn something new and see how to manage acute cases? If yes, do type E, excitement. Type excitement in the chat box and show your excitement to sir. Let's welcome Dr. Rakesh sir. Let's get ready to see some insights on acute cases. Let's show our excitement and gratitude by saying, sir, we welcome you. Type in chat box, sir, we welcome you. Show your excitement, guys. Those who are ready. Thank you so much. Thank you so much, guys. Thank you so much, everyone. Sir, I would love to invite you to share your wonderful experience and insightful journey with all of us. Thank you so much, sir, for giving all of us this wonderful opportunity and this benefit of learning so much new from you. Thank you so much. Over to you, sir.
Hello. Good morning. Good morning, everyone. Am I audible now?
Yes, sir.
Thank you, Dr. Sadhna, for giving a detailed introduction. And the Sattva is maybe founded by me, but it is for all of us. We have all the opportunities, and Sattva can provide all the opportunities which will help us to become a better homeopath. So today it's not just a webinar. Today's session is just to develop the process and inquisitiveness for each and every young homeopath to take up challenging cases and do produce results in these cases, which will boost our confidence and make us feel that really we are actually a physician. So I would just share my screen now. Hope my screen is visible.
Yes, sir. It is.
So today's topic which I have chosen is understanding the pace and the depth of acute diseases in hospitalized patients, or even if the patients are not hospitalized but they are in acute crisis, for the successful homeopathic cures. What we need to understand in such scenario is to understand the disease phenomena, observe the disease phenomena with minutest detail, and understand how the disease has progressed, what are the cause and effect relationship, and these cause and effect relationships should be established while you are taking the history, while you are observing the relatives, while you are observing the patient who is in distress, and while you are looking at the investigations and the disease pathology. So our first and only objective should be why this person is landed up with this particular disease. So here is a case. I think many of the people in this session have witnessed this case. They had a lot of doubts regarding this case. So I thought it is a best case where everybody knows that this patient is improved. But how this person is improved and what is the process behind producing effective results. So it's a case of a 6 years old female. She landed up with high grade fever which was in a range of 104 and 105. The relatives were constantly in contact before the admission. They brought the patient to my clinic, but I said that patient is quite young and quite toxic, so we may require admission, and the relatives agreed for it. So patient had fever with chills. She used to get chilliness, and it was almost 4 to 5 days history. Primarily before 5 days she had some on and off cold and all, and basically overall totally she was ill for at least a week. The fever used to be more in the evening and night. Here now the another point is when you take the history, there are couple of relatives in that particular family. Patient is surrounded by relatives, and you get different history from different relatives. One relative says that she is thirstless. The another relative states that she is thirsty. There is loss of appetite, loud snoring. She had snoring earlier also, but it is pronounced. So now remember, if a child, 6 years old child is snoring, so there has to be some obstruction in the upper airway which is resulting into snoring. So most commonest cause which results into snoring in a child is adenoids, or there is a severe hypertrophic turbinates or a nasal polyp. So the air is entering the respiratory tract and the person develops snoring. There was nose obstruction and lacrimation during fever. So this is what we got. Remaining on detailed inquiry, we saw that, during examination she had adenoid facies. Then she was snoring during sleep, and it had increased since she had developed fever and cold. Background history or the mental history which we tried inquiring, that she stays with her grandmother, aunt and father. She recently lost her mother almost a year back, but since she's a child, she doesn't have active grief, or she's very playful. She's mixed with people around. She's trying to cope up with aunt, grandmother and father. And there was one incident which aunt had mentioned to us, that she was talking at night and she was talking to her dead mother. That is what the history with the auntie gave it to us, that she was talking to a dead mother. But there was no emotional reaction during that phase. When she was asked, okay, what were you doing? She said that I was just talking to my mom. And thereafter, there was no emotional outburst on anything, as reported by her aunt. So right now, summarizing, you have a 6 years old female who has come to you with high grade fever. Relatives are panicked. What should be done? No relative is constantly staying with the child, so, because they all are working. So they are in just shifts. At night, uh, all the relatives, they come together, but over a period of the entire day, only one relative is with the patient. So the history which we are getting is not a uniform history. Only thing which we have now currently is that she is already a lady who has got a child who has got adenoids, and she has got high grade fever, which is mostly at night, and they have measured it goes as high as 105. So at this point, what is important for a homeopathic physician? This is a child. She looks toxic. The eyes are congested. We tried seeing her tonsils. They are enlarged. So now, what should be the plan of action? Anybody can share from the group. It can be interactive. You can share your thoughts. I'm ready to listen. This is a child which will come to your clinic. Now, this is like a training session or a workshop where each one can opine. What will be your plan of action? What will you do with this? Because as you know, she has already lost her mother. Relatives are quite anxious. And she had already visited Cooper Hospital also. The medicines are not working. She had already gone to a local GP. The medicines were not helping. So what we can do in this particular case? As a homeopathic physician, what should we do? Anybody? So as a homeopathic physician, if a child is running a fever for almost 5 to 7 days, first thing what we should do is to understand where is our focus. Where is the focus of infection? That is the foremost thing which we should do. And what is the quantum of the infection? So we have to quantify as well as qualitatively understand where is the disease, which tissue of the body is involved, what is the seat of the disease. That is what is the first thing. According to Boger, the seat of disease identification is the foremost thing, and it will help us to prescribe. It will help us to prescribe. So in this particular case, as I've seen that a girl is running a constant continuous type of fever, which is in the range of 104, 105, and she has already underlying adenoids. For my clinical working proposition is that she may have infection which is related to her adenoids and her tonsils, and that is the reason why she's running continuous fever. And many a times these infection can settle down to the lungs. So we have to understand that probably the airway is involved, the upper airway, and there is a possibility this infection can settle down into the lung. So this is my understanding, first thing. And second thing is, how much is the infection? So there are certain investigation which will help us to identify where is the infection and how much is the infection. So first thing which I did is got a CBC done to understand what is the quantum of infection, how serious is the infection. So as you can see, the counts was 16,800. So again, a 6 years old child, constant fever with high counts, with CRP as high as 74. Normally CRP should be less than 5. So CRP, if we understand in short, is a acute phase reactant which suggests there is an acute severe inflammation in the body, which can be secondary to any infection. So CRP is going to just give us an idea how bad is the infection. You understood? It is in response to any infection or inflammation in the body, it will rise. So here we have come to know that she has high WBC and CRP is raised. Now let us go down and understand what is the situation of her lung. If you see this X-ray, you see the bilaterally there is increased bronchovascular marking and predominantly right-sided haziness is there. Right-sided, predominantly a mild haziness is there, which is not yet consolidated. Means the patient has got increased BVM, means bronchovascular markings are prominent. That means there is some amount of infection which has gone to the lungs, but it is not of the type where she's come into a full-blown pneumonia. She's not in that state of a full-blown pneumonia, but still the infection is settled. So it can be a state of bronchiolitis or bronchitis. If it's a child, it is labeled as bronchiolitis. If it's an adult, then it can be labeled as bronchitis because she is a child. So still we label it as bronchiolitis, or you can just label it as lower respiratory tract infection. But why this infection started is mainly because of this. So as the seasonal change happen, there are viral activation, and the viral activation, in fact, if there is a viral activation, the body has a response or a defensive response to it. So there is hypertrophy of the adenoids, hypertrophy of the adenoid. So there are some tonsils which are there in a nasopharynx. If you can see here, there is a hypertrophy of the adenoids. This is nose, this is a nasopharynx. Okay, so there is a nasal airway which goes into nasopharynx. So this acts as a gatekeeper for the entry of any infection from the nose which is descending down into the lungs. This gets hypertrophied. So if you see very, very closely in our patient, this is the nose, this is the nasal path. If you can see this nasal air level, black color track ends here, and this is the adenoid. So adenoid is hypertrophied to an extent that it is obliterating the nasopharynx. If you can see from the mouth, that you can see the air column which is going down. You can track down till the level of trachea, till the level of the trachea. Here the nasopharynx, it ends here because the air column cannot be seen because the adenoid is obliterating the nasopharynx completely. So that means the degree of adenoid is from moderate to severe type. That is what we have to understand. So there is repeated infection. The infection settles on the adenoids and eventually travels down to tonsils. And then if the immune defenses are weak, then it goes down into the lungs. So if you see an X-ray chest, it is showing that there is a mild bronchitic changes which has developed. So the patient has entered into a zone of lower respiratory tract infection. So this is what we have to identify. This journey where there is from exterior to interioralization of the disease. From the exogenous organism, it goes and affects endogenously the healthy individual, all the healthy host. So all this thing needs to be understood. Now, as far as disease diagnosis, we have reached a 6 years old child with high grade fever, continuous type of fever. She has adenoids. She has tonsillar inflammation. She's landed up with LRTI. Now, what should be the plan of action as a homeopathic physician? Because now if the child is ill, the entire family is, in a panic situation, and they would ask if your medicines you're giving, whether your medicines will be capable of bringing down the fever, whether we should give crocin or whether we should give any other antipyretic because the fever is high. And as we all know, in a child, if the fever is high, there are chances the patient can get into a febrile convulsions. This is another entity which we should keep in mind. If the fever is high, there are chances that the child may go into a febrile convulsions. If the child is less than 5 years, the chances are many fold high. You understood? If the child is less than 5, the chances increases almost 3 to 4 times compared to a child which is more than 5 years old. So this is what we have to keep in mind when we are treating a child, and this needs proper coordination with the relatives, because the relatives are always in a state of panic, and there will be a time where you, even if you don't advise, they will end up giving any of the antipyretic or any of the medicines which will bring down the fever. So coming back to our case, we are now handling a case where we have only limited data, fever and only fever, and the diagnosis. Now, how do we handle? And there is one relative is saying there is thirstlessness. Another relative is saying that the patient is thirsty. So now here is a dilemma of whose history we should believe. Then how do we prescribe? So this is a complete state where you have a paucity of symptom. We have only the disease location, and there is just a modality night aggravation. Fever is the expression of the disease. So fever is an expression of the disease, and just fever as a symptom, which is a common symptom, we cannot just prescribe on that. So here this is a state of paucity of symptoms, which we often get when we are treating cases, maybe, which has been adulterated with allopathic medicines. All the symptoms have been disappeared by taking allopathic medicines, because many a time before patient coming to a homeopathic physician, they try allopathic, they take over-the-counter drug. So now you have a child which is 6 years old, continuous fever, paucity of symptom, and how do we treat it? So there is certain things which have been mentioned in the organon of medicine, especially a section where there is something to do with the zigzag method of cure, where it is mentioned that whatever symptom you get, whatever medicines you have, you prescribe on those symptoms and allow the susceptibility. Susceptibility is the inherent capacity of an individual to fight the stimulus. In our case, the stimulus is infective organism. So that susceptibility throw up another set of symptoms. First, you give a group of symptom, you give a medicine, and then once the A group symptoms disappear, there will be an emerging of the B group symptoms, and you give a B medicine. So this is known as zigzag method, means whichever form of the disease is expressed, you target it. Or second method is to conceptualize it. Now this conceptualization requires a lot of experience. Your disease knowledge should be very strong. And third, you should actually understand where is the disease. So that is very important. We have to, if you miss the disease location, like if the glands are the problem and you identify mucous membrane as the seat of disease, then the chances of missing the prescription is very high. You understood? So this is known as conceptualization. So here we have already seen that she has got significant soft tissue swelling, which is obliterating the posterior nasopharynx, markedly compressing. So that means I am now identifying seat of disease as adenoid. Adenoid is nothing but it's a gland. Okay, so I identified fever in a child. Okay, we diagnosed it. We know what pathology we are handling. We have understood the seat of the disease up till now. The next, the only expression we have that the fever is worse during evening, and it builds up through the evening and it increases by night. So this is what we are handling now. Okay, the seat of the disease, the fever, and the high WBC count. Whenever you get high WBC count, that means there is definitely a bacterial sepsis which is developing. Okay, bacterial sepsis. In a viral infection, usually WBC counts will not rise. There is leukopenia in WBC. There is a leukopenia, that means there will be low WBC count. Whereas if there is a bacterial infection or bacterial sepsis which are developing, then we will have high WBC count. You understood? So these are the three things up till now which we are able to figure it out. So my conceptualization is that glandular affection, night fever, and another important thing is even with such a high fever, she was looking quite matured. Her response and the questions were quite mature, septic state, and she has got tendency to catch cold. So this is what has been mentioned by Boger. Boger, as a stalwart, as a teacher of homeopathy, is always said that there is an expression of the disease, but these expressions often originate from the diseased tissue or disease organs. Okay, so you have to identify these disease tissues and disease organs, because we have got thousands of medicine in Materia Medica which will have affinity for the similar tissues and similar organs. Okay, so we can just match it and we can give the medicine. So this is what we have in our plate, and this has to be done over a period of say 5 to 10 minutes. Here we will take hour, 2 hours, but we have to do it as fast as possible. As fast as possible. I hope you all are getting me. I am trying to just focus on the process, and it is not difficult. It requires training. It requires mental engagement with the case. And that's why in my OPD also, you know that I always want my students, my batchmates, whoever are around, to take the decision. It is no matter whether the decision is wrong or decision is correct. What is more important is try to practice it so that one fine day we are always correct. You understand, all of you? So night fever, glandular affection, high WBC count, child is 6 years old, and all the relatives are standing on your head. Now we have to hit the prescription. Okay. So before we hit the prescription, we should know what are the strategies we are going to follow. What do you mean by strategy? There has to be a plan of treatment which is there in your mind, because when you admit a patient in hospital, I had admitted this patient, so we should always have a plan A ready with us. That is the strategy. And if my plan A is not working, what should be my plan B? That is very important. So my first focus is to settle down the sepsis and the infectivity. My first focus is very clear. I want to improve the general well-being of the patient. I want to restore the vitality of the patient. I have to get rid of the infection. That is my first plan of action. Can we just give medicine and just allow the adenoids to disappear at the first stage? No, I don't think so. We'll give a medicine and adenoids will disappear. No, the first target is to address to the infection and the super added inflammation which has developed because of this infection, settle down the edema, open up the nasal cavity because she's having cold and all, and clear out all the lungs because she has bronchitic changes. You understood? This is my step one of treatment. And step two is managing the hypertrophied adenoids and tonsils. This is a step two of the treatment. We have to tide over, or we have to defeat the bigger enemy or the bigger monster first. So the crisis phase has to be settled down first. This is what we need to keep in mind when we are identifying the remedy, because this is what is the problem which is seen in day-to-day practice. When we see a patient, when the patient is coming to us, we are confused where should we start from, because patient will have some phase which is acute and some phase which is a chronic, or some phase which is acute or exacerbation of the chronic. So we have to tide over first the acute crisis phase. If we are able to handhold, if we are able to comfort the patient during this acute phase, definitely he will give us an opportunity to treat the chronic phase. And if we try to target the chronic phase first and ignore the acute phase, patient will drop out, or patient will try to go for allopathic line of treatment or solution. So this is what I want everybody to understand. And this is very important for youngsters. The people who are senior, they know it. But youngsters, the entire confidence is based on this particular concept. If we are able to treat one patient who's suffering with fever, it gives us an immense confidence to take up a second case. I think everybody would agree, all the youngsters who are there. I think Sadhna will agree with me, Sheetal will agree with me, Saili will agree with me, Yarish will agree with me, and Snehal has seen cases. Many more people, I think Sabha has seen cases, and many more people in this group. I have many more names, but I don't know whether they are with us or no. But there are many people who have witnessed, and it has given. Asavari will agree. Asavari herself has witnessed that entire process. Samika has witnessed that process. Mohit has witnessed that process. So that will increase the confidence. So objective here is to understand the process. We here as a student, we are more interested in the remedy. But if the process is correct, I will tell you that the destination is correct. We reach the right destination. So here, the Burnett writes in his book on diseases of liver. Burnett is one of the homeopathic doctor who has immensely spoken about tissues and organs as the seat of disease, and we should treat them so that we get effective results in pathological cases. And I think uh, uh, even Borland has emphasized on this, and even Boger has emphasized on this. So all big names with the capital B, they have emphasized on this. Burnett, Boger, Borland, and even Boni Hussain has mentioned about this. So what Burnett writes is, when a person is in a crisis, when a person is diseased, it is fine when the organ ill comes from the organism and keeps on coming. The organ remedy is capable of clearing the organ of its organism from the root, so as to speak, for the time being. It is only where the organ ailment is in of the organ and that the organ remedy is adequate. Also, where the ailment is in and of the organ, it is useless to attempt its cure with higher dilution of with the remedy which is affecting the whole organism. So what he is trying to state is that if there is a disease expression which is originating from say a seat of disease is liver, say a seat of disease is lung, and if these expressions are ignored and you prescribe your remedy based on, say, a constitutional picture which is ignoring this organ or the seat of the disease, then it is useless to prescribe. Patient will not be cured, the patient will not get results. That is what he is trying to say. I am not saying that we should not give constitutional. If your constitutional medicine is covering the disease expression and the seat of disease, then definitely you should give constitutional remedy or the remedy which is the holistic, provided provided the disease pathology is not of a terminal type. So it is like if a patient is coming with some symptomatology in a cancer or some symptomatology in a liver failure state, and it is a deep acting remedy, then although it is covering your organs, and if you prescribe, you will precipitate killer's aggravation. At this platform, I am a person who has witnessed the killer's aggravation, and I have actually authenticated that, there is something called as killer's aggravation which exists. I will share an example where I was treating one of the lady who had developed metastasis of the cancer of the ovary, and the cancer had spread to the abdomen, and it has also spread to the liver. I had given her Carbovec as the phasic remedy because she had a lot of dyspeptic symptoms. She was doing very well. She was doing very well. She came up with the modality of 4 to 8 p.m. aggravation, and I thought that 4 to 8 p.m. let's give a remedy which is very popular, that is lycopodium. I gave lycopodium in 30 potency and third dilution, and next day, and in infrequent repetition, next day she got so worsened that she landed up with a acute respiratory distress, the metastasis which were there at the lungs. and she was in distress. She was in distress, and by evening I lost her. By evening I lost her. So you imagine, even if we are using a potency which is quite lower, and that also then you're giving in a third dilution, and that also you're giving, in a very infrequent repetition. But here the problem is the remedy which I selected was a very deep acting remedy, although there was a peculiar indication for that remedy, but that was a misguide for me to prescribe it, and I landed up with a killer's aggravation. So there are a lot of concepts which I have reflected up till now. There was a concept of disease pathology tissue, which has been mentioned by Boger, Burnett, and even Borland. Second, concept of using constitutional remedy in acute diseases, provided their acute disease is not of a deeper nature, which is like cancer or some failure or organ failures, because in such situation it may precipitate killer's aggravation. Okay, so these are few concepts which I have reflected now, and I think this should be taken home so that we can utilize it in our day-to-day practice. However young you are, you always have an opportunity to see a patient. That is what we should understand and keep it in mind. And whatever little knowledge we have, we should utilize it and learn from the teachers or immediate seniors, the interns, which will help us to make a better prescription compared to what we have. So here the day one spike of this lady was 103 and above. When she got admitted in a hospital, we started recording it. Now day two spike, you can see 104, and here is where we came to the remedy. And this was a case which we were treating when actually I was attending Dr. Farooq Master sir's seminar. I was just concentrating. I was deeply absorbed in his teachings, and and I was just conceptualizing this patient. I was sitting in the auditorium, and I released the prescription after discussing with my RMO, Dr. Purva. She was there on floor. She was managing it, and the prescription had was selected. Then you see, first thing in any fever case is, you are where there is a continuous fever, you'll find there is a constant plateau, 103, 104. Okay. First thing is there will be dip. There will be a dip, or there will be crashing down of the fever. This is an indication that your medicine has registered, because this is a question which every young doctor, young homeopath has. How do I know that my medicine has started acting? Because we have to be very sure my medicine is acting, and once we are sure, then only we will continue that medicine, because time is money. Time is money in this particular, because if you don't treat, someone else will treat. Allopathic doctor is always eagerly waiting to treat. You understand? So moment you see there is a dip, I see a dip here, so that means my medicine is acting. Don't worry, the spike, there will be a spike. Don't worry about the spike, because there is an active dynamic infection in the body. If you are trying to conquer your enemy, definitely your enemy will also retaliate. So if there is a spike, don't worry. You go, continue to repeat, continue it, hammer it. You have to stimulate your susceptibility very frequently, because organism is greater than the immunity of the host or the immunity of the patient. So you are supporting the host, so you have to constantly bombard by sending your soldiers. In this particular situation, the soldier is your stimulus, which is ultra dilution. You give in ultra dilution, so you have to repeat. Why I select always to give in dilution is, even if the medicine is a perfect simillimum, and if you give, there is something called as homeopathic aggravation. If you give a complete simillimum, there are chances of homeopathic aggravation. Patient doesn't know there is a homeopathic aggravation. Patient will feel, oh, I am not getting cured, and patient will panic. So in order to combat this homeopathic aggravation, I give a medicine in dilution, and I repeat it, because I want to raise the state of susceptibility or increase the susceptibility of an individual, so that the host can conquer the disease pathology. The first indication, now here the take home message is, temperature recording is very important. You cannot treat a fever patient without recording the temperature. The first is to follow the basic discipline of medicine. This is what I have been telling all my students. Even students, they forget to report that. They will call me up that, sir, I have got fever. And then I ask them, how much is the fever? So I have not recorded. So this should not happen. I think everybody will agree. We have treated ample of fever cases just from fever chart. Fever chart will help us to understand how great is the fever, how high is the fever. Fever chart will help us to know when is the fever coming more frequently. You'll come to know what is the time modality. Respect time modality, because time modality is very important in cases of in cases of fever. Plus, it has been actually emphasized by these stalwarts like Dr. Boninghosen. He has mentioned about the relevance of time modality. And even if you read Bogus Synoptic Key, the initial pages only give mentions about the time. So how important is the time? And we ignore time. And any fever case, whichever is the diagnosis, whatever is the diagnosis, whichever is the seat of disease, we shouldn't miss the time modality. Second, if there is a crash in the fever spike, this is a definite indication that your remedy has registered. So when initially you're prescribing, you should look for the crash in the fever spike. If you can see now, the tallest peak of the day is 102.4, tallest, and the prior you saw it was 104. So now your maximum spike a day prior was 104. Now it has come down to 102.2. Then this is what we need to remember. We need to believe that medicine is acting, because if you believe and if you're well versed with this phenomena, you will tell the same thing to the relative. You'll show your fever chart and say, first day fever was 104, 105, and now the spike is 102. So definitely the infection is under control. That is what we need to transfer it to our relatives, so that relatives are relaxed. If the relatives are relaxed, we'll get more time to treat. Plus, patient will also get more confidence. Now you see the day 4. We have crashed down the fever, and the maximum spike which we are getting is between 98 and 99. That means we have already conquered the fever. That means fever is indirect expression of the infection. That means the infection is under control. You understood? This is how we have to go step by step. We have continued the same medicine, higher potency, frequent repetition, in order to stimulate the susceptibility to a level where the person is able to conquer the infection. We are not giving any antibiotics, because this is the commonest question which will any child who is ill, the first thing the parents will ask you whether we should give antibiotics, whether we should contact a pediatrician, whether homeopathy can help it, whether a child is a good candidate for homeopathy, whether homeopathy is slow. So in this particular case, it is quite clear the homeopathy is not slow. Homeopathy can be given in a child. Homeopathy can even address to a high grade fever as 104 and 105. And we are scientifically documenting each and everything. This is what we should do. So now after the end of the seminar, I would just expect that any fever case, first thing a person should do is to record the temperature. We should motivate the relatives as well as the patient to keep the temperature record. And I'm telling you, if you just see the temperature record, you'll pick up the remedies like anything. I have picked up arsenic by midnight aggravation. I picked up lycopodium by evening aggravation. I picked up mercsol by night aggravation. Okay, and many more remedies. You understood? So this is what we need to. So after you see the fever spike coming down, we have to support with an evidence whether actually the fever has come down, or the infection is also settled down. So that can be seen through the investigation. So if you see the investigation on day 3, it is 10,280. First WBC count was 16,800. and now it is 10,280. So you imagine you have brought the patient back from the infective phase into a normal WBC range. So this is an evidence which shows the infection has settled down. Okay. This is what the patient looks, smiling face. And this is, I'll share a video where, how are you feeling? You're better? You have fever now? You have headache? You have headache? No? No? Pain? Throat pain is there? Nose? Nosy is okay? Nosy? Nose is blocked? Is closed? Nose is closed? Yes or no? No, no? Very good. You're happy? Very good. What are you eating now? You like it? You like it? You want me to get something for you? No? Dada will get it for you. Who's going to get it for you? So now who will guess the remedy? Anybody? Any guesses?
Merksol.
May I know your name, madam?
Shrutika Tupe.
Very good. So how did you reach Merksol?
So she's having night aggravation of the fever, then also pathology of the glands that is covered by Merksol. Adenoids and the tonsillitis she was having, those glands are directly acted upon by Merksol.
So very good. So imagine if the process is simplified and conceptualized and understood, anybody can make up the prescription. Anybody can pick up the remedy. You understood? So that is what I wanted to tell you. The challenge lies in conceptualization. The real challenge for a physician is which is the most important data in the case, filtering out unwanted data and picking up the relevant data or the relevant key feature of the case so that we give a right medicine. So if you understand this, there are many more remedies coming up for differentiation. There are remedies with glandular affections. Even silica can come up. Hipasulf can come up considering the sepsis. There are other remedies like belladonna coming up. But all these things are there. But what is more important in this particular patient was the depth of the pathology, the sepsis, and with this sepsis, patient was very calm. She was behaving in a very, very mature manner. That was another thing which was striking me. So when I saw rubric a precocity or mature in Kent's repertory, I found mature only one remedy, which was Merksol. If you can just have a reference from the repertory, Kent's repertory. And another important thing was night aggravation. Night aggravation is very classically seen in mercury group. So the remedy which I selected was Merck as my step one. Step one means the treatment strategy I had mentioned. There are two steps. First step is treating the infectivity and the sepsis. Sepsis means it is reflected through the WBC count, which was 16,000. Okay. So I started with Merksol as the remedy. What is more important given in, I'll just read out from Borik's Materia Medica. It is mentioned that every cold which enters the body will allow the glands to get enlarged. Every cold which enters the body or the patient gets the cold, the glands will get enlarged. Glands will get enlarged. It is mentioned and surprisingly it is written in the skin section of Merksol in Borik. gland swells every time the patient takes cold. This is a very important thing. Then it is also mentioned that worse at night. All the symptoms of mercury is worse at night. So this classical night aggravation is basically more towards merc compared to hepar and silica. And another important thing is suppuration and the glandular affection. There are abscesses and suppuration which is there, and there is a destructive inflammation which is there, which is markedly given in Merxol. Another important thing is the affinity for glands, and these glands eventually gets converted into abscesses or suppurative quinsy. It is known as abscess of the tonsil, which is known as suppurative quinsy, quinsy with difficulty to swallowing. So these are few things when we are reading Materia Medica, we have to give minute attention to these details. If you give attention to these details, this will allow you to do a finer differentiation with the other close coming remedies. Some person may say, why don't we give Baraita carb? But Baraita carb has more affinity as an hypertrophy and glandular affection. You understood? The child will be in an immensely adult state. So whether Baraita carb will be a right remedy to be given at this particular stage. Here, the glands have enlarged, but with the glands, there is an infection. With the infection, there is sepsis. If you don't treat this child for another 2 days, the WBC count will shoot up as high as 20,000, 21,000. So, so in such scenario, there will be no option left, and then the modern medicine doctors or pediatrician will give higher generation antibiotics. So 1M, frequent repetition in dilution. So frequent means what? As frequent as 10 minutes. So there will be, there are references given in chronic diseases where Hahnemann himself is written that you can give as frequent as half an hour or less than that. Even in Organon of Medicine, it has been mentioned in the aphorism that you can judge what is the appropriate dose for the disease you are treating. So some disease 1 hour will be a frequent dose. Some disease 5 minutes and 10 minutes can become a frequent dose. So we are done with case 1. You want me to start case 2, or we'll summarize by concluding this case? The expression of the disease, what we learned from this case, these are very important things which I have learned from 17 years of success and more than success failures. Expressions of the disease. When you say expression of the disease, means symptoms are more important. But identifying the correct one is very important. Patient will come with lot of symptoms, but what is the key symptom? That is more important. Relying completely on relatives' history is deception. You cannot rely completely on patient's relative. Right now we are writing a paper which is a group of cases from the pediatric age group, and how pediatric age group you get fooled with the history which is given by the relatives, because relatives, they have observation, but all the relatives do not have that kind of resolution to observe the minutest detail, and they sometimes add their own side of the story and give you the symptoms. Conceptualization should be based on concrete evidences. Means if I say I am treating infection and I will give Moxol, then it is not a concrete evidence. I have to create the concrete evidence, or I have to prove the concrete evidence by doing relevant investigations. In our case, did a CBC, and we did a CRP, and we did a X-ray chest, which was telling us that, the infection is settling from upper airway to the lower airway, and there is sepsis. So concrete evidences is very important. Never hesitate to investigate a patient. Even if the patient's relative is reluctant, you keep on explaining. Don't be hesitant. And this confidence will only come when you know your symptomatology, when you know your diagnosis, when you know your clinical history taking. Always respect the generals of the case. If you see, I conceptualized, but I only picked up a very important general of the case. That was a general modality. I paid a highest respect to it and kept it till the time I reached Moxol. So that is very important. Fulminant disease process and speed of disease evolution will determine how fast you should act. There are cases which I have seen when I was under training where patient was having 104, 105 fever of pneumonia, and the treating physician was so adamant that he didn't want to repeat a dose. He said that my one dose will do the enough. But this is what I absolutely, I'm against it. If the disease is percolated or it has invaded the host to a deepest level where the vitality is compromised, where the person is in acute distress and there is a situation where the host doesn't have energy to revive on its own, then give the medicine. And if it is a correct medicine, you have to repeat. In correct medicine, incorrect repetition will allow the disease to progress to more deeper organs and the person will go into complication. And this is my experience. I was treating case of UTI. My medicine was correct. Just because I didn't give a frequent repetition, the patient landed up with cystitis. But the same medicine, when I started giving it very frequently, the cystitis also disappeared and UTI also disappeared. You understood? So you have to understand the continuity of the organ. You have to understand the continuity of the organ. You have to understand what is the proximity of that organ. If I don't treat a gallbladder, definitely my gallbladder infection will percolate into peritoneum and it will lead to peritonitis. There will be rupture of the gallbladder. So all these concepts have to be understood, and definitely the knowledge of pathology and general pathology, disease knowledge, as well as the medicine knowledge is very important. Then there comes the remedy differentiation where you read those italics line and you understand and you make your own understanding that how deep this medicine is acting, because this understanding will always be based on your knowledge of disease. You understand? It is the diagnosis will be secondary, but if you understand the pathology, you will know that I want to address to this pathology, and this is the remedy which has got complete correspondence or similitude to this disease pathology process. And if I will address to it, then I will be in a better state and my patient will get cured. So this was the case which I have done, maybe not in very short, but at least I have tried to focus on all the processes. If the group is ready, I can continue with second case. Hello, am I audible?
Yes, sir.
Yeah. So my take-home message from this particular case is never get scared, because I am telling you, when I started my practice by treating a case which was 104 and 105 fever. Symptom was perfectly bingo to belladonna. I gave belladonna. Patient went into aggravation and landed up with 106. Even in spite of giving in a dilution, then the relatives came to me and they said, "Sir, तुमच्याशी होत असेल तर करा, नाही तर आमच्या मुलीला आम्ही ना पिडियाट्रिक डॉक्टरकडे घेऊन जातो." This was the way he came and he insulted me. Then I said, just give me 2 hours. I will restudy the case and prescribe. And then the same totality I studied and I came to a remedy which has a deeper action, and that was CPR. So imagine both belladonna and CPR, they are get worse when they are exposed to, the head is exposed to, what we say as head bath. When you take a head bath and you get, and CPR also when you get wet and head bath, you get. But the disease phenomena is different. And our objective is to identify the disease phenomena and whether we are proceeding, because symptomatology may match. You will find that belladonna will cover more than the CPR, but the actual disease phenomena was covered by CPR and patient got better with CPR. Coming morning, patient was 99 degree Fahrenheit, and the same father came to me and apologized that, I was very rude to you, and I thought you are very young and you are new, so you may not be able to treat my child, and I was worried. So these are various emotional reaction you have to face, and you have to be ready, you have to be strong. You should not leave the practice and run away, right? That is what uh, so I start with another case. This is another beautiful case, and this is a case which is actually, Dr. Sheetal Jaising, Dr. Prajakta Vade was there in this case, and I think this case was also seen by Dr. Saili and Dr. Yarish. So this is a case of a 60-year-old female. She is already suffering from thyroid, diabetes, blood pressure. Last 15 to 20 years, last 15 years she is suffering from all this thing, and I knew her because I was treating her during her all this illness, but she was very irregular on treatment. She was already taking allopathic medicines. She was already visiting cardiologist and the diabetologist, and she was on the standard regime of anti-diabetic, anti-hypertensive. She was also taking diuretics. Okay, so once the diuretic is started by any physician, so you should get alert. In a person who is diabetic, hypertensive, and there is a diuretic. Diuretic means a therapeutic agent which will increase the urinary excretion, which will increase the urinary output. And the reason why they start diuretic is there is some amount of fluid which is remaining in the body which needs to be thrown out, or else it will produce secondary symptoms like breathlessness or like cough or like dyspnea. Okay, so a patient came to us already taking diabetic medicine, already taking thyroid supplements, already taking antihypertensive. She came to us with cough since 1 month, which was worsened since 4 days. Means she last 1 month she was coughing, and this cough was of such a type where she would just sit up. She would not lie down. She would just sit up, and she has lost her sleep because she is just sleeping in a sitting position. So imagine the severity of cough and the position patient is assuming. Any respiratory complaints, whether it is cough, breathlessness, always be careful of the position with which the person is assuming or taking in order to get the comfort. And this will be the keynote, and this will help you to identify the right medicine. So this is our agenda. When you take the history, you identify. Patient will come and say, "Arey, मेरे को बैठ के रहना पड़ता है. I have to sit up." So you have to ask that patient, how long do you sit up? Even if you should not take it very casually, better by sitting. This is another mistake which we make. We don't intensify the symptom. How much marks the patient symptom has, whether it is 1 mark symptom, 2 mark symptom, or 3 mark symptoms. You have to learn to identify the intensity of symptom. That is very important. So you imagine a lady who is already on allopathic medicine. She's already a diabetic, hypertensive, and she's just sitting up. For 1 month, she's not getting enough sleep, and now last 4 days, she's worsened now. And the entire thing was started after the change of weather. The climate had changed, and that was in December. I think she got this problem in December and Jan, and came to us in Jan, along with cough, which is worse lying down. She has to sit up, and definitely a night aggravation around 3 to 4 a.m. aggravation, which patient had reported. And we had confirmed time and again. How can you be so sure? Then the patient says that at night at around 3 to 4 a.m. I have to sit with the relative, said that I have to sit with the patient. I have to comfort her. I have to rub her chest. I have to, give her some hot water so that she becomes comfortable. And I am also not sleeping because this patient is not. So relative was, the patient's daughter was her relative, which she had come for admission. Expectoration is thick, white, difficult. She's better by hot water. There's a lot of chest pain and tightness along with this. And this breathlessness is not only while she is, in bed at night, while lying down, she is also breathless when she's walking around. So this is the main symptom. So from this, we have to identify whether this cough which the patient is coming up is cardiac origin or respiratory origin. This is the first thing which we should do. Whether it is a cardiac origin, or it is a respiratory origin. If she is, in so much of trouble since last month, 1 month, whether we are handling only the respiratory illness or the cardiac. So now, any patient who is coming with cough for last 1 month, if it is respiratory origin, patient will definitely have fever along with it. Fever will be there. This is very important. Second, patient will develop a wheezing. A cough will not remain just a mere cough. There will be spasm. Respiratory origin will have spasmodic cough. Means the patient will come up with actually audible wheezes if it is respiratory origin. Either it will be a wheeze which will be audible, or there will be fever because of consolidation of the parenchyma of the lungs. But cardiac cough will persist without any fever, and patient will majority of the time emphasize on the position which she acquires, and the cough and breathlessness gets precipitated. So there will be higher role of position, and there will be absence of fever until and unless it is secondarily infected. Okay. So this is a very important differentiating point. Along with this, patient had immense weakness and lot of sweating. What we got from the history was patient was quite reserved. She has gone through a lot in life. She has bared a lot of things, but she has a lot of tolerance. And recently she lost her husband. There was a grief which she had never actively discussed with anyone. She had grieved, but she had not actively discussed what she has gone through. She, she had gone through a phase of sadness, but she didn't express her emotions. When took her, we did her examination, it was 150 by 90, pressure 96% saturation. What we were surprised was her sugar levels, which was 581, and she had creps which was symmetrical creps. Again, an important thing is usually when we see a respiratory problem and patient has cough, there will be asymmetrical crepitation or asymmetrical findings. Here in cardiac, this patient has predominantly, we are suspecting cardiac, so she has symmetrical presentation which is in the basal part of the lungs, where there is bilateral crepitation. And another important thing which we found was there was raised JVP. JVP was raised. JVP is jugular venous pressure. Okay, there was a raised JVP which is seen through a prominent jugular vein, internal jugular vein, which gets prominent where you are made the person lie down on 45-degree angle, and you find it is very raised. Usually it should collapse, but it was raised. So this was a position she was assuming, and we were also surprised that she was sitting in this position, and this position is when I was sitting to take her history at around 11:30, 12 o'clock, and she is saying that I cannot go beyond this. I said, why can't you sleep? So I said, immensely breathless. I get immensely breathless. So she sits in this position and she is slightly comfortable. So now she's sitting up and she's slightly bent forward and she's better. This is how she sits at night. When she takes her legs up, this is how she sits. And these are the cough paroxysm, short bouts of cough. Short bouts of cough. So you feel that it's a short bouts of cough. There is no spasmodicness in the cough. There is no spasm. So these are the various things which we need to see. There is no rattling. So if there is a bronchitis or there is a COPD, there will be a lot of rattling. The person doesn't have energy to remove the expectoration. So she gets short bouts of cough. Usually these short bouts of cough is seen in either pleural pathologies or if it is cardiac, because pleura is outside the lung. So there are chances that there is pleural irritation which is expressed in form of reflex cough. There also you won't get any expectoration. There will be short bouts because there is pain and inflammation in the pleura. Person will hold the chest when the person is coughing. So this is how you differentiate between the pleural and the cardiac. This is how she's sleeping, She's just closing her eyes, coughing. This is how she's sleeping. Short bouts. Don't treat it like a URTI. This is what I am trying to tell. We may end up making a mistake. We will end up not investigating the person. Although the patient doesn't have a very, very deep or doesn't have a spasmodic or a wheezing cough or a rattling cough, it doesn't mean that patient doesn't have a very grave disease. We need to investigate. You don't treat it like a URTI. So she had already done few of the investigation, right? Because she was suffering from last 1 month. I've already mentioned that she was a case of DMN HTN. Her creatinine was 2. So she is already into a chronic renal disease phase. So that means you're now handling a case which has got hypertension, diabetes, thyroid with a chronic renal disease, CRD, CKD, okay, chronic kidney disease with a low hemoglobin of 9.7. So our vitality, you understand why am I trying to reiterate all this thing is now you have to judge the state of susceptibility by looking at the vital parameters like HB, saturation, her sugar levels. So how is her vitality? She is into a storm, body is now trying to fight back. There is a problem and now the sugar is raised. You understand if there is any stress on the body, there is an activation of the stress hormones. The stress hormones, the few of the stress hormones are epinephrine, norepinephrine, cortisol, okay, aldosterone, angiotensin, okay, adrenaline, atropine, all these are the stress hormones which get secreted, and all these stress hormones will first try to give immense energy to the body, and the commonest source of energy is glucose, and that's why the sugar will rise. So imagine a diabetic patient who's already on controlled line of treatment from a modern medicine comes up with 581 sugar. So this is an alarming sign that the body is under stress. As I was suspecting that this doesn't look a simple respiratory cough because she's lingering with this for 1 month and now she's constantly in a sitting up phase and she's not able to lie down. So this is known as orthopnea. Orthopnea. Now when we grade this orthopnea, she has dyspnea which is on rest. So she has got grade 4 dyspnea. You should understand this is a grade 4 dyspnea where a person even at rest, even at rest cannot 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 be comfortable, cannot be comfortable, cannot be comfortable. Glycosylated hemoglobin. See, you can say glycosylated hemoglobin is 11.6, which gives us an average, which gives us an average of 3 months. So when we want to see how is the overall disease control, we come to know from glycosylated hemoglobin. Glycosylated hemoglobin. So she has cough with difficult expectoration, which is worse at 3 to 4 a.m. So now somebody will come and ask me, okay, orthopnea and paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea is classically seen in person who is in a state of cardiac failure. We have now proved that patient is in a state of cardiac failure with the previous investigation where her ejection fraction is just 20%. Normally the ejection fraction should be around 50 to 60%. She is almost having a compromised heart. She has developed a cardiomyopathy, dilated cardiomyopathy. Cardiomyopathy means there is alteration in the dimension of the chambers because of the chronic stagnation of the blood in those chambers. So heart becomes dilated. It becomes dilated chronically. The heart is overloaded, so it remains dilated because the dimensions have changed. The contractility of the heart is poor because of the chronic stagnation, and this is mainly because the heart muscles have gone weak. especially the left ventricle, and that's why that dynamically on 2D echo you see that ejection fraction is just 20%. So here night aggravation is very common to the disease, because any cardiac patient who has got cardiac failure will have night aggravation. 3 to 4 a.m. aggravation is also supposedly common, but these common symptoms becomes characteristic because of its intensity, where patient is saying that no, I cannot lie down. Lying down aggravation, I have to sit up, I have to bend forward in order to be comfortable. And 3 to 4 a.m. aggravation, which patient is telling that it is happening last 1 month. So then that means it is happening every day for last 1 month, means 30 days. So it is 30 plus. 30 plus, the intensity is 30 plus. We cannot ignore it. You understood? All of you are understanding. So it is a structural or functional impairment of ventricular filling of the ejection of the blood, and there is signs of fatigue which develops because blood is not reaching the circulation, plus heart itself is not having enough blood because the heart is not pumping. There is no blood into the coronary circulation. So patient develops orthopnea. Orthopnea means dyspnea on lying down is known as orthopnea. Paroxysmal nocturnal cough or paroxysmal nocturnal dyspnea, where patient cannot lie down. As soon as the person lies down, starts getting the cough and the breathing which comes is Stokes breathing. So this is a classification. Patient is in class 4. Patient is class 4 category, where heart failure with a very, very markedly reduced ejection fraction. So imagine you are now handling a very multidimensional case where there is a acute decompensated heart failure, which is grade 4 with reduced ejection fraction in a diabetic patient which is already hypertensive, also has got endocrinal issue. So imagine already patient is having hypothyroidism, so it leads to slowness. Bradykinesia is a classical feature of hypothyroidism. So imagine the state of susceptibility of this person. So patient is in a very low state of susceptibility, structurally irreversible zone, grade 4 dyspnea, grade 4 type of heart failure with ejection fraction of 20%. So this is a very risky patient. What a modern medicine person will try to do is get a pro-BNP. Pro-BNP is an indicator which is classical to a heart failure. But in our patient, we have already done a 2D echo, which is giving an evidence that, it is a heart failure. And if you address to what is the cause of heart failure, for that, we have to do an angiography, which will find out whether there is underlying ischemic heart disease which has resulted into heart failure. Means if there is atherosclerotic changes in the coronary artery, there will be less circulation to the ventricle, and eventually the ventricular muscle starts dying and the ejection fraction starts dropping down. So this is what we understand what is the stage of the disease. So we will directly go on to the medicine line of treatment. So this is an extreme state of susceptibility. If you are not aggressive at this point to treat this patient, probably the patient will die because of the fluid overload. So this is a critical state which is actually threatening the existence of the person. This is a reference which we have got from Principle and Practice by Dr. M.L. Davle. In such situation, we have to pick up a medicine and bombard this medicine in a very higher potency. It's a dynamic acute exacerbation of chronic miasmatic disease with fully developed symptoms. Patient is already from a psychotic phase has gone into a syphilitic, where there is a death of the heart muscle cells without making much noise. So the syphilitic dimension has got two. Either there will be a very, very aggressive and destructive presentation of the syphilitic dimension, or there is a phase where person goes silently into a non non-projecting type of disease, where there is a silent disease which goes and completely finishes the actual organism or the constitution. So there are two methods of expression in syphilitic disease. Silent killer, that is something called as a silent killer, and second is a very fulminant distress and the person goes and dies. So state of susceptibility is low because there are only few symptoms that also supposedly common to the disease, but we made it characteristic by its intensity with which the person is suffering. So why such kind of strategy is important is because we need medicine to be prescribed. We should be sure what medicine we are prescribing. So we took 3 to 4 a.m. aggravation, cough with cardiac disease, dyspnea which is better by sitting in a bent forward position. So the remedies which came up here was Kalikap, arsenic, Kalibai, lachesis, lyco, phosphorus, causticum. Now out of this we want a remedy which covers the acute phase, but for differentiation we can use the disposition, the nature of the individual. She is a very, very tolerant lady, very quiet. She is able to take up the load of the family. She is able to even understand the grief in a very subtle manner so that others don't get disturbed, and she is reserved. So considering this, the remedy which I thought either a sepia or kalikap can be a remedy which can, because all the other remedies are quite expressive, or they are quite vocal about their suffering. She suffered this for 1 month, and she, until unless the relatives didn't notice, she didn't even report about the heart failure. So the remedies which came for differentiation was arsenic, kali, and lachesis. So it has been mentioned that in arsenic the person will be, even if the person is dyspneic, will be extremely restless. You can see from the video, she's calm and she's just sitting in one position without complaining much. I had to ask her on the entire history time and again so that we prescribe the right medicine. Similarly, lachesis is also a very good remedy where there is constant atherosclerotic, senile atherosclerotic process. Both Kalikab, arsenic, and also lachesis, all of them are worse by lying down. The modalities are all three of them has got night aggravation. What is more important is the functional capacity of the heart is reducing. So we need a remedy which has got an effect on the contractility, as well as it has a diuretic action. It can throw out the fluid from the body. So the remedy which has got lot of fluid accumulation has to be selected. So remedy has to have 3 to 4 a.m. aggravation. Amongst the night aggravation, 3 to 4 a.m. aggravation was very marked. Sitting up was very marked, and it has got a cardiac dyspnea that is more marked. So I selected Kali Carb in 10M potency. Now you'll ask why we use 10M potency, because when we are using a remedy, you have to understand the crudeness of the drug has to come down. Crudeness of the drug has to come down, but its effective action has to enhance. So as you grow higher in potency, you actually ultra diluting the crudeness, plus you're enhancing the functional capacity of the drug. And here, if you understand, this person is in a low state of susceptibility, but it is in a fulminant phase, or it is a phase of threat where the person is almost on the verge of dying. So if you want to revive such patients, we may have to use a higher potency with a dilution, with a frequent repetition. You understood? So it is a fulminant state of susceptibility which needs to be addressed immediately, or else the person will go into a complete cardiac arrest. So here Dr. Samuel Hahnemann in his chronic disease has mentioned that sometimes the state of susceptibility or the organism is in such a state that they cannot overcome the threat or the all the seriousness of the disease with how in the acute phase of the disease without sacrificing a part, means there is definitely going to be some amount of damage and there is some amount of setback which our organism is going to get. That is what is the meaning of acute phase, acute crisis. Okay. And in such situation, we may have to use a medicine which is, you know, it is given more or less very frequently, very frequently. In some cases, it can be given every half an hour, or some cases it can be given every 2 hours or 3 hours also. Unless the symptom starts disappearing and the other symptom starts appearing, or you have to repeat to an extent. Many a times you get an initial homeopathic aggravation and then you can stop the repetition, but in our case we constantly kept on repeating because there was no evidence of homeopathic aggravation. In fact, there was an evidence of homeopathic amelioration. And also Borland in his pneumonia textbook has mentioned that there is something called as crisis method of treatment, where you bombard the susceptibility so that you annihilate the infection, you annihilate the organism, you annihilate the crisis phase of the particular disease. So if we come in very closely with Kalikab, it is mentioned cardiac dyspnea, breath is short, patient cannot walk, suffocation, dyspnea, leaning forward amelioration, 3 to 5 am aggravation. So it is mentioning that there is lack of reaction, suffocating, cough. If you read bogus synoptic key, it is mentioned 2 to 3 am aggravation. And if you see the seat of disease, very important is the muscles and specifically the heart muscles. So what are we treating? We want to increase the contractility of the ventricle. So what is our target organ? Ventricle. And in that ventricle, what we are trying to target is the muscular contraction. You understood? So we are trying to treat that. And similarly, we are also trying to reduce the load on the heart by improving the excretion of the urine from the body. So patient's causation was change of weather, and this causation is mentioned in Borix Materia Medica, where it is mentioned there is sensitive to every atmospheric changes. And it is written that it is a dropsical remedy. Dropsical remedy, if you can see this, page number 325 of Boric. And it produces hydrothorax. It produces hydrothorax, and it is mentioned that it has threatened heart failure. Threatened heart failure. So these are references from different source books. Clark, Fatak, Boric. So if you can see in Clark, it is mentioned from there is operation of the chest because of the hydrothorax. So when I'm trying to pick up these lines, I'm trying to say that this medicine has an affinity or it has potential to produce fluid accumulation in the body in various cavities, whether it is a pleural cavity or a pulmonary congestion or pulmonary edema. So this is what. So follow up on day 2, cough reduced, pain reduced, BP reduced, saturation improved 98% on sitting. We continued the same medicine. Now you can see she is lying down comfortably. So just 24 hours, she was sleeping fast asleep. She did not sleep for last 1 month. Now she is sleeping. There is no cough. She's sleeping comfortably. Imagine a lady who's in the sitting down position. So now at this stage, I would like to just tell that detailed observation, noting down the symptoms is one part, but what is more important is repertorizing, and after repertorization, taking reference from materia medica is very important, because when you are in crisis, you are so much over burdened by the disease presentation or disease manifestation which the patient is coming. So you are in a desperate situation where you would like to help the person. But if you are not methodical, if you don't follow a proper system or proper process, you will not reach a right remedy, and we'll end up losing the patient. Either patient will succumb to the illness, or patient has to be shifted to modern medicine. So that will be just a, it will really what we say, it will demoralize us. It will what we say, devastate our confidence. So what we can see is, we repeated the creatinine creatinine which had raised to 2.6. Now it came back to 2. First reading in December was 2, then in between the fresh reading was 2.6, and then again now it is 2. It has come back to its original state. Her saturation is now much better, 99. Her pulse rate is also now improved. The contractility improves. That is only reflected as the pulse wave, and which you can record on the as a pulse rate. Now you see the magic is, we in fact stopped the insulin in this patient. She was shifted on OHAs. And you see, when you're reducing the insulin, plus you are just continuing with the OHAs, and only with homeopathic addition, the sugar has come down to 257. Means when she came to us, she was taking insulin, she was taking even oral hypoglycemic agent, and in spite of these two drugs, she was having 581 as the sugar. But after, when we intervened with homeopathy, what we did is we stopped the insulin and we continued homeopathic medicine. And while we were continuing homeopathic medicine, the stress environment of the body started reducing. The adrenergic drive, which was very high, started reducing. So automatically the strain on the heart comes down, the adrenergic drives come down, the sugar will also start settling, and it is coming to 257 as the reading. So now the moral of the story is how to identify the disease organ. Second, in that organ, what is the tissue involved? Okay, this is what we understood. So identifying heart failure, the muscle as the seat of disease. As you all know, potassium is good for heart. If you understand the doctrine of signature also, potassium is one mineral which is actually there in our body. It is supposedly to be intracellular more than extracellular. And as and when even the modern medicine doctors, when they they find a person having any hypertension or cardiac disease, they advise that you can give potassium. Okay, but in our patient, potassium is also risky because she also have chronic kidney diseases. So it is best to give a potassium in a potentized manner, which is Kali. Okay, Kali is nothing but it is a potentized potassium. Okay, so here we are addressing the heart failure, and when you potentize, we see that according to bogus concept and bogus synoptic key, it covers heart muscles as a seat of disease. Okay, then totality of symptom, however less the totality is, try to pick up the most characteristic symptom, which is the core of that particular disease is shouting and telling you symptoms. What is the core symptom? Okay, then there is importance of remedy differentiation. And so imagine you are not, in spite of patient being on diuretics, in spite of patient being on insulin, in spite of patient being on OHA, in spite of all these things, patient was having all this infection, plus patient was having this cardiac failure. It all got solved by giving right simillimum in right potency and right repetition. You understood? So this is how we have to manage acute emergency cases. So any doubt, please ask. Hello, am I audible? Hello, Dr. Yarish,
Yes, sir, you are audible.
Dr. Sadhna, yeah. So any doubts, please ask, because see, in a busy OPD, it is very difficult for us to, uh, address each and every questions. So now I have shown you two extremes. One person is right in the start of their life. One person is in the start of their life. That lady, that girl, she's 6 years old girl. It is a pediatric case, and one one patient who's at the at the elderly age group level. So we are handling two extremes state of susceptibility, two extremes of ages, two extreme form of diseases. Okay, one is infection and hypertrophy, and one is completely degeneration and failure. So you understand the miasms. The first disease was primarily psoric to psychotic origin, and the second is psycho to syphilitic origin. So this is a journey of disease. This is a journey of life, and you ask questions so that you can apply. I'm not saying that your all your doubts would be solved in one session, but at least if you gain enough confidence to take up a case with a little difficult pathology, I think this seminar will be my work will be done for the for from through this seminar. So any questions, please ask. Either everybody has understood everything, or everything is a bouncer. No questions.
Good afternoon, sir.
Hi Talat, how are you, Dr. Talat?
I'm okay, sir. I'm fine.
Yeah, tell me.
Wonderful seminar, sir. I
Yeah, thank
had a doubt regarding the second case, that in that case, when the remedy was selected, it was quite similar. It was deep acting. Also, the pathology was advanced. So, how it could have caused killer's aggravation in this case also.
yeah,
So,
it
what
could
was
have.
your thinking at that time?
Yeah. So see, identifying, there is a difference between a low state of susceptibility and fulminant and extreme state of susceptibility. So I classified low state of susceptibility into a more further classification of fulminant. Means the organism is almost to a stage where there is no time left. We have to stimulate it in a way where it has to be in dilution also, and it has to be frequently also, but the potency should be high. So by doing this, I was trying to what I kept in mind is there are chances of homeopathic aggravation. So that's why it is best to treat in this format after admitting the patient. This is what I thought. There is a chance of killer's aggravation, but considering that she is able to drag on for almost a month she is dragging on. Okay, and plus her other parameters, like if you say the pressure, if you see the pressure, it was 155 by 90, so she was not into a cardiogenic shock state. So I took up that took up that challenge of using a higher potency and frequent repetition, because I thought it is best to give ultra dilutions. Finally, when you say 10 m as a potency, it is where the crudeness is low, the dilution is high. Okay. So if the disease is irreversible, it is contrary to the thought which we have been taught in the classroom, that when the disease is pathological dimension, you should use 30. In fact, there are phases in a disease which is pathological and reaching a terminal stage, where the crisis needs to be addressed with a higher potency. When we understand higher potency, it means the crudeness has gone to a very low level, and now only the dynamic energy is left. But when you're using this higher potencies, we should use in a dilution format, and you should be keeping the person under observation. Where you find if there is a killer's aggravation, you should completely switch it off. Never use this killer's aggravation, I mean the strategy which can produce killer's aggravation where the vitality is completely depleted. So in such situation means If the oxygen level is say is very, very low, like 70, 80, or there is a situation where, patient is vitality is compressed. So in such situation, we can use 50 millisiemen in frequent repetition. 50 millisiemen in frequent repetition. So there are chances of killer aggravation, but best is to use in dilution. And in fulminant states, it is said that when you are addressing acutes, especially functional zone, then you can go very, very high. There is no problem. There is no chance of killer aggravation. But when you are addressing structural irreversible pathologies, there also you can go higher potencies, but go with dilution technique and with cautious repetition. Once first 6 hours, I'm sure that no, the patient is actually moving towards the normalcy, then I am really assured that, this person will not land up with a killer's aggravation. Talat, you got?
Thank you, sir. Yes, sir. Now it clarified my point. Thank you, sir.
So it is a matter of experience. There are two schools of thought, but I have treated such cases with lower potency where I have given repeatedly, patient has not improved at all. Then patient will require probably, allopathic support, like, you have to give, other forms of diuretic, modern medicine diuretics. So instead of that, you give a higher potency with caution, with dilution, seeing few dosage without any killer's aggravation evidence, you give it frequently. And it is a fulminant state of susceptibility. We have not much time left. Any other questions?
Sir, I had a doubt.
Yes, Dr. Suwani.
Sir, in the reportization you did, there was one more drug, Kali Bai. Because I just checked it out in the Materia Medica, it also has sticky expulsions. So why didn't you consider that drug?
Yeah. Basically, patient was, first of all, a chili patient. Secondly, if you read Kalibai seat of action is more on joints. Kalibai seat of action is more on the mucous membranes of the respiratory tract and the GI tract. You understood? So we have to now come to a remedy which covers the pathology, heart as a muscle. So that's why I'm time and again in my method of working, I always try to, I think whoever works, we always, now though, I don't even need to tell, the people who are working with me, they will first open up and see whether the seat of disease, the tissue which we are targeting is covered by this particular remedy or no. So as I had shown on bogus synoptic key, it is clearly written that muscles and that also the heart muscles. So that particular, what we say, tissue action of the remedy is important, because if you have that specificity, we will miss on the remedy. There are many remedies which is lying down aggravation. Even bryonia is lying down aggravation. Even for that matter, arsenic is lying down aggravation. So there are, arsenic is lying down aggravation. There are many more remedies. Phosphorus is lying down aggravation. So there are ample of remedies. But what we are trying to search is the tissue affinity. And it is given in the section of the tissues and the organs involved in bogus synoptic key that it has an action, and plus patient is chili, plus Kalibai predominantly has got rheumatological affections, and it has got predominantly respiratory involvement and GI affections. So this is the three. So, and it has got more of ulcerative and inflammatory pathologies and exudative pathologies. Here what we wanted is the fatigue, muscle fatigue. So that is very important, and which is cardiac fatigue.
Yes, sir. Got it. Thank you, sir.
So this kind of exercise is very difficult, because you imagine each case you have to take so much of references, but it comes by practice, and many a time it becomes a automatic phenomena where you don't have to even think and your mind starts working. Initial 10 cases, I am just telling you, count on your finger. Initial 10 cases you'll have a difficulty, you'll find, array, it is too much for me. But after 10 case, 10 11th case, you will find it so easy. I think people been, witnessing in IPD, whether Dr. Sadhna is there, Dr. Juveria was there, Dr. Talat is there, Dr. Yarish is there, Dr. Saili is there, whoever has actually witnessed IPD, they have seen, okay, then it becomes automatic. It becomes an autonomous process, Any other questions? So Anam Chaudhary has mentioned that in second case, the pulse was 96 beat per minute on admission, but after the remedy in the next follow-up, pulse was 64 beat per minute. So how we can come to know that it's a good sign or a dangerous sign? Okay, very good question. See, what happens is now we are dealing with a case of a heart failure, right? So heart failure has two components. There is either tachycardia or a bradycardia. When a person with a heart failure goes into tachycardia, it means the body has got any form of stress. So if the heart is beating at a higher pace and it is already weak, so we are trying to whip a tired horse. The heart muscle is already fatigued and it is beating at a higher pace. Okay, so it is possible in cases of any stress on the body or infection. And if it persists, suppose this patient gets fever and continues to be breathless, eventually this heart will fail. After giving the remedy, patient's pulse rate had come to 64. We have to be cautious because if it is coming down to 64, it means either the heart rate is reducing because of the cardiogenic shock or heart rate is reducing because the stress on the body is gradually diminishing because the effort which the person was taking in order to breathe in and breathe out, there was a breathlessness, there was a pulmonary congestion and edema, it is eventually setting down. So that may reduce the heart rate from a tachycardia zone to a normal zone, or sometimes it can come down. So we have to be cautious. We should continue to keep a check on the pulse rate or the heart rate. Plus at the same time, we should also keep a check on the saturation. For example, in this case, if after giving Kali carb, there would have been bradycardia, and with bradycardia, there would have been hypoxia where the saturation would have dropped. That means we are going against the Herring's law of cure. Herring's law of cure, or we are trying to basically precipitate either there is a disease progression or you have induced killer's aggravation. That is what Dr. Talat was trying to ask. So we have to keep an eye on combination of blood pressure, heart rate, pulse rate and saturation, and the clinical picture of the patient, whether patient is comfortable or patient is distressed, whether the JVP is furthermore rising or patient is able to lie down comfortably or no. So all this thing has to be collectively taken into account. So here if the heart rate, pulse rate has come down, I am trying to be more relaxed because now the stress on the body is reducing. That's why the heart has to pump less. The tachycardia is coming to a normal range. And as it is, patient is already a person who's suffering from hypothyroidism also. Plus patient has already dilated cardiomyopathy. So in a person who's stable with dilated cardiomyopathy and hypothyroidism and underlying chronic disease, 64 to 70 heart rate is also fairly acceptable. You understood? Yeah, Anam, you got it? Any other? So these questions, the questions which Talat has asked and Anam has asked, these are all super specialty questions. Huh? And that means they were listening to the presentation very, very carefully. And because I'm to be very, very honest, keeping the finger crossed, this second case was very dangerous case because I was also skeptical because she was relative of a pathologist, and all the family members are, attached to multi-speciality setups. So one of the relative is working with Sion Hospital. So imagine if you are able to create a dent in patient, in cases or the diseases which are actually born or which is actually in the family of people who are already from a allopathic background. It really gives us enough confidence, or it reinstates the confidence that, homeopathy, if it is rightly used in a right method, it will definitely be a therapeutic science. Any further questions? I think it is lunchtime. Everybody is hungry. So I will hand over the dais to Dr. Sadhna and Dr. Yarish. Dr. Yarish, I am signing off, Dr. Yarish.
Thank you, sir. Thank you, Dr. Rakesh Gupta, sir, for making us, the younger generation, understand how to treat acutes and for boosting our confidence in prescribing. Thank you, sir, once again for an enlightening session. I would like to thank Sattva Charitable Sanstha for giving this platform to nurture and help budding homeopaths by giving them a new direction. Lastly, I would like to thank our audience for being patient listeners. Hope you all enjoyed this session. Thank you and have a lovely afternoon. Thank you.
Thank you. Thank you, everyone.
Thank you so much, sir. Thank you so much, all. See you all next time in another yet exciting seminar. Thank you.